Good afternoon, everyone. My name is Dr. Brad Stovall, and I'm an interventional pain physician here in OrthoVirginia. I specialize in the treatment of acute and chronic orthopedic spinal conditions, ranging from osteoporotic compression fractures to disc herniations to arthritis, to spinal stenosis, and back and leg pain after back surgery. Today, we're going to be talking about a new and exciting procedure that can be used to help treat chronic lower back pain. It's called the Intracept procedure. As we go through the talk, I'm going to first give you a nice overview of some basic spine anatomy principles. We're going to talk about some of the common causes of chronic lower back pain, and then go over some treatment options, specifically the Intracept procedure. We're going to go to the camera here. So I've been in Richmond now for over 10 years practicing medicine here, and we was trained at Virginia Commonwealth University and completed my interventional pain fellowship there, where we learned various advanced spinal procedures. And so the Intracept procedure is a way that we can help address some chronic lower back pain. So when we first look at spinal anatomy, the spine is a fascinating structure because it has to be able to do many things. When you think about a gymnast or a ballerina, the spine has to be flexible. And if you're thinking about like an NFL running back, it has to be able to withstand many types of forces. So the spine is not a typical joint like you think of when you think of your hip or knee. So the way I like to look at the spine is essentially a bunch of blocks of bone stacked on top of each other, and they're separated by the discs, which are the cushions that help support most of the weight of the spine. And so here's a simple spine model that we have. And when we talk about the spine, each functional unit of the spine involves two bones, the vertebral body here on top and the vertebral body below. And in between there, you have the disc, and that's the shock absorber. And for a frame of reference, this is like looking at someone from the side. So here's the front and here's the back of the patient. And the disc is here, and the disc is a shock absorber. So you see when we squeeze, when you have press and force going through the spine, it goes through the disc. And when we're young and healthy, about 80% the force going through the spine travels through the discs. And as we go through life, you start to get wear and tear or degeneration of the disc. And as this disc starts to wear out in the front, it can put pressure on the joints of the spine. And you have a pair of joints on each side of the spine called facet joints. And then this model here, this is a joint on this left side that is inflamed and irritated. So as this disc starts to wear out, it puts pressure on these joints. And all of these things are very normal findings. So it's normal to have wear and tear of the disc. It's normal to have arthritis in the back. And just because you have those degenerative changes doesn't mean you necessarily have pain. So in certain patients, they're able to live their life just with some arthritis and no major pain. But in many patients, it can be very debilitating. And so we look at chronic lower back pain. It's no surprise that it's very common. About 10 to 13% of patients have chronic lower back pain. And chronic, we can define it in different ways, but generally we describe pain that's beyond the normal healing process, or pain that's been there for at least 3 months. And back pain has a lifetime prevalence, almost 85%. So almost everyone experiences either an episode or can develop chronic lower back pain. And we see it most common in ages from 30 to 64 as one of the leading causes of disability. And so when we look at common causes of chronic lower back pain, the main structures that can cause problems are disc herniations or disc degeneration. So when we're young, when we're in our 20s, 30s, or 40s, most episodes of back pain are more often related to the discs. Sometimes that can cause sciatica or pinching of the nerve, and sometimes it just causes back pain. As you go through life and start to have wear and tear of the discs, that pressure from that disc starts to get shifted to those facet joints, and then you start to get arthritic pain. And we'll talk about how that shows up later. And then there's also a joint that can cause about 10 to 15% of back pain in patients. That's in the hip. It's called the sacroiliac joint. Kind of think about that's where your wallet is in your hip pocket. And then as you get disc degeneration and wear and tear, you can start to have bone inflammation. And that's what the Intracept procedure treats. And so the term we use for that is vertebrogenic pain. But essentially it's pain from inflammation of the bone that started off with a disc degeneration. So when you look at this spine model, you have the bone on top and the bone on bottom. That's the vertebral body. In the middle, you have the disc. And on top and bottom of that disc, you have a piece of cartilage called the end plate. So we start to see inflammation of the bone when that disc starts to damage the cartilage, kind of like you see in knee arthritis. As you get cartilage damage, it leads to bone inflammation. So what do we do for back pain? So whether it's acute or chronic, we start off with our typical treatments, including medications, muscle relaxants, physical therapy, or chiropractic treatment. And sometimes that's all we need. We could do a short course of some physical therapy, work on some core strengthening, and helps manage a lot of that arthritis pain that we talked about everyone gets. But then when that's not working, we have different tools like epidural steroid injections, most commonly used for sciatica, and then radiofrequency ablation. More commonly, that's been used for arthritis pain in the back. So those joints we talked about called the facet joints. But we now have a new way to address the inflammation in the bone, which is what the Intracept procedure treats. So this is an example. We've been talking a lot about anatomy so far. So this is a picture of an MRI. And this again is looking at the patient from the side. So on the left of the screen, that's the front of the patient. On the back of the screen, that's the back of the patient. And the squares are the bones of the spine. And you see they're separated by the discs or the cushions of the spine. And then as you get degeneration, you can look at that lower disc that has all the white inflammation around it. That lower disc has worn out and it's damaged some of the cartilage of the spine. And now this patient has a lot of bone inflammation leading to their clinical picture and their pain. So a common question we get is how these different structures cause pain and how do patients show up to our clinic. So the type of pain that comes from this bone inflammation is pain when you're sitting too long in a car, like difficulty with car rides, difficulty sitting, trying to stand at the sink and reach over and do dishes. That can cause a lot of pain. And then we see patients as they try to get on the floor to play with their kids or bend over to play with their grandkids. All that pressure on the front of the spine puts pressure on the inflammation and causes pain. We'll often see those patients sometimes can say, I can go walk for miles, but I can't sit, I can't bend, I can't do the things that I want to do. That's the typical pain pattern that we see with this, but there's a lot of variation in between. We talked about the arthritis joints earlier, those facet joints. And those facet joints are typically the opposite. So it's usually pain with standing and walking, and if you sit down, it gets better. So we kind of use your symptoms to help guide, some of our treatment options, and of course, what we find on the imaging. So the Intracept procedure is a catchy term that we use to describe the procedure, but what it's really doing is it's burning a nerve called the base of vertebral nerve. So this is, again, another spine image. You can see the healthy disc right above the clear structure, which is the disc, and then you have the bone. And this nerve, the base of vertebral nerve, actually lives inside the bone, and it sends the pain signals from that part of the cartilage in the bone. So conveniently, what we've been able to figure out over time is you could actually go in with a needle and then burn that little nerve, and it stops the pain signals from the joint. It stops the pain signals from that bone inflammation. And the convenient thing about this procedure is it's a one-time treatment. If you've ever heard of burning the nerves of the back or facet joint ablation, that tends to be repeated about once a year because the nerves like to try to grow back. This nerve in particular doesn't have any special coating around it, so when we do this one burn, it doesn't grow back, and it ends up being this one-time treatment for this bone inflammation at this level. And this is just an image of how we perform the procedure. So it's a procedure performed in the operating room. There's no major incisions made, but it's a minimally invasive procedure where we put at the top left of the screen, we put a small needle into the bone and we move it towards where the nerve is on the top right of the screen, and then we perform the ablation. You can see in the bottom right what that looks like when it's in a good position. And so we talked a little bit earlier about some common symptoms of when you have this bone inflammation. It's pain with prolonged bending, sitting, or lifting, and that pain when you're like standing at the sink or trying to bend down to pick up your children. And so the other thing that we'll see, not everyone has the exact symptoms that we list and describe with these symptoms. So anything that puts pressure on the cartilage. So if you're young and you're very active with this kind of chronic midline lower back pain, any like jumping, running can also aggravate it. So it's not just that you have pain with sitting. It could be anything. As the more active you are, because you're putting stress through the disc and stress through the spine, it can cause pain from that bone inflammation. And so the procedure, like we talked about, is performed in the operating room. It's a minimally invasive procedure that's safe. It's got good long-term evidence, which we'll discuss in a moment. There are a few conditions that you may not be a candidate for this procedure. The kind of the big things we always are looking for, tumors, infections, but outside of that, if you've had a history of spinal fusion at the level that we're considering to treat, we can't access that level. But the good news is if you've had a spinal fusion, typically above or below the level of fusion is where we see more of that bone inflammation and more of the degeneration. And when we do this procedure, we're actually going into the bone and burning a small lesion in the bone, and so it does temporarily weaken the bone. So over the years, we understand that osteoporosis is a contraindication, because if you have osteoporosis, that's a term used for when you have reduced calcium or weakened bones that puts you at risk for fractures. So if we do this procedure, if you have a history of osteoporosis, you have a higher rate of a compression fracture after the procedure. So if you do have a history of osteoporosis or compression fractures, then this would not be an ideal procedure for you. So anytime you hear about a new procedure coming out like this procedure has been FDA approved. It's been in development for over 10 years. So it sounds like a new procedure, but it's been out for some time, and there's been more and more evidence mounting. And there's been very good clinical studies that have been done, but both sham-controlled level 1 studies looking for good relief, and it has a high safety profile, and it also has good long-term relief. Any treatment that we do for chronic lower back pain, we want it to have good outcomes, but also durable, long-lasting outcomes. And because of the anatomy of the spine in this area, we're able to do this treatment one time and get good long-term results, and that's what we've seen in the studies that have been done. And so when patients say, is this procedure going to help my pain? What we're looking for is at least 50% relief of any pain treatment that we do. And so if you have the right clinical picture, meaning if you have the right symptoms and you have the concordant or the correct imaging findings, so we've seen at least 50% pain relief in about 75% of patients. So most patients clinically that have the symptoms and the imaging findings will do quite well with this procedure. But we will often have patients that are get 80 to 100% relief and do really well from the beginning. And it's a very safe procedure with minimal problems. This is just some data from a few of the different trials that were done. And so when we're looking at what to expect after this procedure, we talked about how it's performed in the operating room. So after the procedure, about half my patients don't even take pain medicine. They're just a little sore for a few days. And then the other half will have a few days where they need some pain medicine, but patients tolerate the procedure really well. Whenever we look at pain relief after the procedure, some people get pain relief right away. So within the first few days or a few weeks, they say, doc, I'm doing great. I've had 80 to 100% relief. I'm able to do all the things I couldn't do. I'm a little sore from the procedure, but I'm doing well. And then about the other half of patients we'll say, I'm maybe 50% better. I feel like I'm doing a lot better, but it's just still a little stiff. I'm not sure. And in both of the major studies that were done, we've seen that pain relief continues up to about 3 months. So I like to tell patients, we know how you're doing the first week or two after surgery. Let's really see where you are at that final 3 months. They showed continued pain relief out to about 3 months. And then really at about 3 months, the pain relief you have is the pain relief you have. And these studies have all looked at functional outcomes. So what kind of functional improvements do we see is what kind of pain relief do we see? And you can see the graph on the left and the right look very similar because the functional improvements and the pain relief all were concordant with each other. So I know we've covered a lot of different ground with the anatomy and some of the treatment of the Intracept procedure, but essentially just to go over how we look at things, when you come in with chronic back pain, we're looking for what are the structural causes. We're looking for, first, is this pain from the front of the spine where the discs and the bone inflammation is, or is this pain from arthritis? And those are treated differently. We have different treatment options. And so that kind of guides our treatment if conservative options aren't failing or aren't working. And to be a candidate for this procedure, you have to have chronic back pain that has failed treatment and has been ongoing for at least 6 months. This is not something if you're playing a sport over the weekend or you pull your back out and you're out of work for a few days. This is not a procedure we look at. This is for something that's not responding to the normal things that we do, physical therapy and medications. And the good news is it can provide good long-term relief. Like anything in the spine, we can see these changes in some patients that don't have any pain at all. So it really depends on, are things getting better? Because some people get this bone inflammation and do well, and it seems to go away over time. And some people have this persistent nagging pain. It's not really sort of touch. It's just kind of always there, deep in the spine, and they're tired of dealing with this. So this can be a good option. And just to kind of go over chronic lower back pain and basivertebral nerve ablation. Chronic lower back pain is common. It's known to cause a lot of functional limitation and disability. So if you think you might be a candidate for this, or you're just having persistent back pain that you want to see if there's any good options, we'd be always happy to evaluate you and go from there. We're going to open it up for some questions.
We are. Thank you so much, Dr. Stovall. So we will be answering questions that were submitted earlier and questions that are submitted live. So if you are watching now, we invite you to start putting your questions in the Facebook Live chat. Not all questions will be able to be answered, but we will answer many of them. So our first question is, can I have this procedure if I have a pacemaker?
Yeah, so you can have the procedure if you have a pacemaker. When we do this procedure, when we get into the bone and we burn the nerve inside the bone, the technology we use just keeps all the electricity right at the level of the lesion site, so there's no interaction with the pacemaker. And being in the operating room, the pacemaker is monitored the whole time as well, but there's no interaction with the equipment with the pacemaker.
Thank you. Our next question is, can I have this procedure for neck pain?
So the procedure is FDA approved for treating the L3 vertebral body down to the first sacral vertebral body, or the S1. So L3 through S1 are the levels that are approved to treat. And there's currently no approach to get into the neck for that, and it's not approved for the use in the thoracic spine. So really, this is a treatment for chronic lower back pain currently. There may be down the road some iterations for treatment of the mid back pain, but right now, the only treatment availability is for L3 through S1.
Thank you. Are there any age limitations on this procedure, either upper age limits or lower age limits?
So on the lower age limit, we want this procedure is something that we want, if it's going to be performed in someone on the younger side, it would be in a skeletally mature patient. So I think at the age of at least 25 or higher, but typically we're going to see disc degeneration and bone inflammation like this in patients that are, getting into the 30s and 40s. On the other end, on the higher end of the age, the biggest limitation for this, if you have the appropriate clinical picture and imaging findings, is just your bone health. So as we get older, we all lose calcium in our bones. And so we always want to mitigate the risk of a compression fracture after the surgery. So we'll do some screening for osteoporosis, make sure the bone's healthy enough to do the procedure.
Thank you. Is the procedure covered by Medicare or commercial insurance?
Well, the Medicare has national coverage for this procedure, and about 60% of commercial payers will pay for the procedure. And so sometimes we get approval right away for the procedure. Sometimes it takes a few months to get approval from the insurance companies. Not every insurance company covers this, but the majority do.
Thank you. Would this procedure replace a spinal cord stimulator?
That's a good question. So we use, for those of you that aren't familiar with spinal cord stimulators, they're an electrical device that can be placed in the spine to help treat back pain or nerve pain before or after back surgery when appropriate. And so think of this as treating more of the mechanical pain of the spine. So patients can often have a stimulator, some say for a nerve injury or some issue with prior back surgery. But if you develop pain that's localized in the lower back region that has the appropriate imaging findings, this could certainly be used in a patient that had the right clinical picture that does have a spinal cord stimulator.
When should chronic lower back pain be a concern for something beyond discomfort? Could it cause lasting negative effects?
So when we look at chronic lower back pain, that defines as being there for 3 months. So anytime you come to see any of our docs in clinic, we're going to get a history, we're going to review what's going on and get some imaging. And we use our MRI imaging or CT imaging to further evaluate the structure. So certainly we could look for things, we always make sure there's not infections, cancer, tumors, which we occasionally find. And then when we're looking at, chronic back pain, we're looking at different treatments to help mitigate and reduce that.
Would this procedure help with sciatic pain down the leg or just the pain in the back?
So this pain is a treatment for chronic back pain. It does not address any sciatica symptoms. So typically, if you just have chronic back pain and the sciatica symptoms are really not the major concern, this would be a possible option. If you do have a lot of sciatica symptoms, we like to approach that first. We always try to protect the nerves first, calm down nerve inflammation before looking at some of these chronic back pain treatments.
Thank you. Can I have this procedure if I've had disc surgery?
So there's different types of disc surgery, the main one being a discectomy, where the surgeon shaves off part of the disc that's causing the nerve compression. And sometimes, for instance, surgery for a discectomy will take care of the leg pain or the bad sciatica or the nerve damage, but then patients can still have some lingering back pain. So surgery doesn't always make back pain go away as much as it can help nerve inflammation. So we'll oftentimes have patients that have had a discectomy, they've done well from a sciatica standpoint, but they have this lingering back pain that will go away. So this can be an option in those patients.
Can I have this procedure if I have had a spinal fusion?
So spinal fusion is done to help stabilize the spine and improve alignment. And so if you have screws into the bone, that's kind of the same area that we go with our equipment. So if you have a spinal fusion, we can't do the procedure at the level of the fusion, but typically when we see degenerative changes after a spinal fusion, it occurs above or below the fusion. And then that's the area that has that bone inflammation. So oftentimes it's not the level of the fusion that's the problem, it's the area above or below. So if we do see those inflammatory changes, we are able to treat them.
Is this procedure suitable for people with pain caused by arthritis?
So that's a good question. So we talked a little bit earlier about the anatomy of the spine. So arthritis in the spine, the discs and the facet joints go hand in hand. So the longer you're on the earth, the more activities you do, the more you're going to have degeneration or damage to the disc and then cause arthritis of the joints. So I kind of look at the pain in the back as being from two parts of the spine. One is in the front, that's more of our disc issues and bone inflammation, and one is from the arthritis. So the arthritis or inflammation in the bone we can treat, and then if that's not where the pain's coming from, then we can treat the arthritis on the back of the spine. So it really depends clinically what type of symptoms you're having, and we have different tools to target that.
Thank you. Not going to have a question up on screen for this because it's too long, but we have people asking if this will help with various conditions of the spine. So I'd like to mention them and have you respond. So one of them is spinal stenosis. Would this help with spinal stenosis?
So for spinal stenosis means narrowing of the spine. So we talked about our spine being a bunch of bones stacked on top of each other, and they form a tunnel or canal that protects all the nerves. So that's the spinal canal. Think about like a tunnel that you drive through the mountains. And so stenosis means narrowing of that. So if someone has spinal stenosis, they have narrowing of the spine, and some degree of that can be normal. But as you go through life, if you start to have more and more spinal stenosis, you can start to have compression of the nerve. So if you have spinal stenosis and you have a lot of pain down your legs or weakness or numbness, that has to be addressed first. But you certainly could have some degree of spinal stenosis. Sometimes people can have even moderate levels of stenosis and not really have any sciatica or pain down the leg. So you could perform this procedure at the level of spinal stenosis if there's not a major nerve compression, causing symptoms.
Thank you. What about scoliosis?
So scoliosis is just like with anything, there's varying degrees of scoliosis from very mild to very severe. So this treatment can help treat pain related to the bone inflammation that often patients with scoliosis will have just because of the increased stress on the spine. So it really depends on, like we said, symptoms and then the imaging findings. And the procedure is more technically challenging with scoliosis, but we certainly perform that in patients with scoliosis. It really just depends on what's going on clinically, but also what the imaging findings show.
And what about patients who have retrolisthesis?
Retrolisthesis, so we go back to our spine model here. So think about the spine again as a bunch of blocks stacked on top of each other. There's a normal curvature, there's normal alignment that we like to see. But if this bone shifts forward or backwards on the one above or below it, we call that an anterolisthesis or a retrolisthesis. So when there's abnormal alignment of the bone, we can still do the procedure, but it depends how much alignment abnormality is. Is there any instability? So when we have you come into the office, we'll get an x-ray to make sure, even though the bones may be out of alignment, make sure they're not shifting and moving abnormally. If you had instability of the spine or you had a significant nerve root compression with sciatica symptoms, then you may not be a candidate. But we certainly have done the procedure in patients that have anterolisthesis or retrolisthesis.
Thank you so much, Dr. Stovall. That is all the time we have for questions today. Dr. Stovall, would you like to close?
So we're always happy to treat any acute or chronic cause of lower back pain. This Intracept procedure is a new and exciting procedure, but it's just part of the many tools that we have to help address acute and chronic lower back pain. So if you want to come in for an evaluation, happy to evaluate you and give you some recommendations.